My name is Tim. I use he, him pronouns, and I am the member connector and program coordinator at the coalition. We're also joined by Jody, Sarah, and Rachel from the coalition. Hello, hello. We have a great agenda today that I'm excited to walk us through really quick. We are going to first discuss some changes to the public charge rule that would impact a person's application for citizenship. We're going to be walked through that by Sylvia Rivera, a staff attorney from Colectiva Legal del Pueblo. Very excited for that. If you have any clients who are not citizens that are looking to be, that would impact their access to benefits. We're also going to be joined by some of our community partners to discuss the existing behavioral health crisis response systems, including 988, crisis connections, and other warm lines, quote unquote. Next, we are going to discuss some highlights and recap from some important budget advocacy that we've been doing over the past few weeks, particularly our coalition members, Sarah Robbins and Allison Eisinger, pursuing a budget that reflects the need for fully funded human service contracts and fully compensated human service workers, ensuring that compensation stays in line with inflation and that contracts stay in place. And then finally, we'll have some member announcements. Before we get started, I do want to pass it over, sorry, I'm getting ahead of myself. I would like to invite a volunteer to read the mission that is on our screen right now. If anyone cannot see this, let me know. But we would love a volunteer to read our mission to be.
We mobilize our community to challenge systemic causes of homelessness and advocate for housing justice.
Thank you very much, Elizabeth. Thank you for jumping right in. All righty. And now that we've reviewed our agenda and our mission, I want to pass it over to Sarah Robbins, our Public Policy Director, to discuss some highlights from our budget advocacy work.
Good morning, everyone. Thank you for joining us today. I'm actually just going to give a quick preview of what Allison will cover more in depth at the end of our training, or at the end of our meeting today. She will talk about what we advocated for and won at the King County Council with the King County budget. The City of Seattle budget is not yet final, but it is close to final. And we will talk about what we have been advocating for, what is in there right now, and what we expect will be. We are also going to try something. We're going to try and do a thank you thank you photo that we will share with the King County Council members and the Seattle City Council members, thanking them for the wins that we got this session. And so what I am hoping everyone can do while we're in this meeting is we're going to ask that everyone that wants to participate and be on camera make a little thank you sign. Oh, I have to unblur my background, I think, for you to be able to see this. Let's see. Okay, there we go. So if everyone can make whatever piece of paper you have. Oh, yep. Oh, look, my team members have theirs too. Make a little sign that says thank you or thanks. And we will have everyone hold those up at the end of the meeting, and we will get a group virtual thank you photo that we will be able to share. So get whatever paper you have, whatever pen you have. It can be as fancy or as simple as you want to make it. So looking forward to the rest of this meeting and sharing more with you at the end about city budgets. Thanks. Tim, we'll pass it back to you.
Awesome. Thanks so much, Sarah. All right, so we'll look forward to that a little bit further in our agenda today. But for now, let's dive into talking about some changes to the federal public charge rule, which impacts folks who may be applying for citizenship. To walk us through this, we have a subject matter expert, Sylvia Miller from Colectiva Legal del Pueblo. I would like to pass it over to you, Sylvia. Welcome.
Thank you, Tim. Yeah, I'm Sylvia. I'm an immigration attorney, and I used to work in public hospitals in New York City and did a lot of public charge talks there. So I'm gonna share my screen. Let's see. Possibly. We go. And yeah, I'm just going to share some, oops, that's not what I want to do. Share some brief overview of public charge rules. Some of you may be very familiar with these already. Some of you maybe not. So yeah, I'll just dive right in. So today I'm just going to cover what is the public charge rule, a little bit of background and history to give context about the changes, more practically looking at when it applies and when it doesn't, and specifically what benefits might be a problem for people under these rules. And at the end, some takeaways and frequently asked questions, and then there'll be time at the end for questions if people have it. And also my email if people want to, shoot me questions afterwards. That is totally fine. So basically, the public charge rules are, it's a ground of inadmissibility, which is basically just there's a very long list of reasons that the government can use to deny someone a green card. And the actual language of the law is right below there. But again, the grounds of inadmissibility are only going to apply when people are applying for very specific applications. It's not just kind of a general, it's not a general thing that will apply to everyone. It is also a ground of deportability, which is a different long list of reasons that the government can use to deport someone. I'm not really going to talk about that because it's basically almost never used ever. So it's not going to be relevant 99.999% of the time. So we'll just talk about the inadmissibility piece of it today. Just a little for me, I find a little bit of history helpful to give context of kind of like why the rules are the way they are. This is a very, very archaic rule. That's one of the older rules in immigration law, and basically came at a time when, the US government didn't want people to immigrate who they thought were just going to end up, paupers. It's the word they used back then. And partly that's because back in the 1800s, there wasn't really all these like modern public benefits. If you couldn't support yourself, usually people would go to institutions. They'd be in asylums, workhouses, orphanages. So kind of if you couldn't support yourself, the government kind of like had to pay your room and board and support you entirely. So today, we don't really use institutions in the same way. We have all these different, we have food stamps and we have cash benefits and we have Social Security and all these things that didn't exist. But basically that history is partly the reason why it's applied pretty narrowly, and it's only applied to people who the government thinks will be primarily dependent on the government for subsistence. So that just provides a little bit of context, and then we'll go into the contemporary rules. Again, so under the Trump administration tried to expand the public charge rules so that it would cover a much broader range of these more modern benefits. So people who got Medicaid, people who got SNAP or housing vouchers or childcare subsidies, they wanted to expand it to kind of, people who weren't completely dependent on the government, but were getting this assistance. So none of those rules have actually been in practice since March of 2021. And so, I only share it in case people say, a few years ago, I heard X could be a problem. And that's what they're probably referring to are these Trump era rules. But most of today, I'm going to talk about what the actual current rules are. And basically what the Biden administration did is they basically changed them back to how they had been from about 1999 to 2019. So it is a change, but it's basically a change back to the old status quo. So again, today, I think the first thing that I look at in terms of public charge is looking at who it's going to apply to. And like I said, it's going to apply to a small subsection of non-citizens. And really it only applies to someone who's applying for permanent residence, which is a green card, through a family member. They're married to a US citizen, they have a US citizen kid, or they're a kid and their parent is sponsoring them. People in that situation, they have to show the government, their sponsor meets certain income requirements, and there's certain benefits that can disqualify them from that green card application. So if we look at who it doesn't apply to, it doesn't apply to basically everyone else. So if you are applying for, or you were granted, asylum, refugee, you're applying for a U visa because you're a crime victim, you're applying for special immigrant juvenile status, you came as an unaccompanied minor, or, DACA, basically anything that's not the previous slide, you're not being sponsored for a green card by a family member, the public charge rules just don't apply to you. They're just completely irrelevant to the adjudication of your application. And so that includes people who are, they were an asylee and now they're applying for a green card. Public charge rules don't apply. If someone has a green card and they want to apply for US citizenship, it doesn't apply. So again, the vast majority of people that I work with, the public charge rules are just, irrelevant. And the government's not going to look, you can receive any benefits, you can have as low of an income, you can have zero income, and that won't affect people's application at all. So then if someone is in that category of people where the public charge rules are going to apply, they are applying for a green card, they're being sponsored by a family member. The common question is, what benefits will the government consider? And again, given that the Trump era rules were revoked, it's kind of gone back to that previous standard of really only benefits in which people are basically completely relying on the government for their day-to-day subsistence. So that's people who get public cash assistance for income maintenance. So that's SSI, kind of that general assistance, cash assistance, or people who are institutionalized for long-term care at government expense. So like a nursing facility, people who are in long-term care, they're not going to be discharged in the near future. And that's being paid by regular or emergency Medicaid. So the result, if you look at the intersection of kind of who it applies to and what benefits are considered, the end result is that it's almost never going to apply because you can't get SSI if you're, undocumented. And you're not going to get cash assistance if you're undocumented. So that, even though that's the rule, it basically applies to almost no one. And then people who do qualify for cash assistance, refugees are eligible for various benefits, but the public charge rules don't apply to them. So yeah, I guess the main takeaway is like almost no one is going to have a problem. I have been practicing immigration law for almost 11 years, and I have encountered one person that I was like, oh, you will be like, you have a public charge problem. And that person was someone who was living at a long-term care facility in New York and had married a US citizen who also lived in the same long-term care facility. And the husband wanted to sponsor her, but because she was, in this care facility being paid by emergency Medicaid, was like, oh, you actually have a public charge problem. But that's basically one person out of hundreds of people that I've spoken to. So if you look at what the government is not going to consider benefits wise, they don't consider any other benefit besides the ones on the previous slide. So food stamps, housing vouchers, WIC is a huge one because tons of people get WIC. They get pregnant, they're offered WIC, and they're like, oh my gosh, is this going to be a problem? Emergency shelter, pandemic stimulus checks, any kind of earned benefits, unemployment, workers' comp, things like that. And then also any medical benefits, as long as you're not living in long-term institutional care, basically anything else is not going to be a problem. So vaccines, testing, Apple Health, short-term rehab, all of that's not going to count. Oopsies, sorry. And then any benefits that family members get. So if you have an undocumented parent and their kids are disabled and the kids get SSI, that's not going to be a problem for the parent because the child is the recipient of that benefit. So a few short caveats. There are different rules if people are here on a valid tourist visa that they want to keep using. This isn't visa overstays, but people who, they came less than 6 months ago, they want to keep traveling on that tourist visa. If they accept any public benefit for any reason, they can have their tourist visa revoked. Again, it's usually a very small subsection of people that you might encounter. There are slightly different rules for people who are going to apply for a visa overseas. The rules are very similar, but slightly different. And then, of course, obviously, if people are misrepresenting their income, because they work under the table and they're not disclosing it, and then they're getting benefits that they're not entitled to, that obviously is a completely separate issue that very often is a problem for their immigration applications, but is a completely separate issue than the public charge rules itself. So a few final takeaways. Main one being using benefits is almost never a problem for people who are applying for green cards. Like I said, if you're eligible for benefits, the public charge rules probably don't apply. And if they do apply to you, you're probably not eligible for any of the benefits that would disqualify you. Again, often there's people who maybe don't have any status at all, and they have this kind of vague question of like, if I accept WIC, will it be like a black mark against me if to like fix my papers? And again, same answer. If they're eligible for the benefit, it's probably, it's not going to be included in the public charge analysis, and anything that their kids get. If their kids are getting food stamps, if their kids are getting SSI, that's not going to be, imputed to them. And then also I just let people know, because a lot of people come from places with really centralized governments and they don't understand like the state federal divide in the United States. Most benefits are awarded by the state and every immigration agency is federal. So I just also let people know like there's no central computer where, ICE gets a little ding saying, oh, Sylvia Miller applied for Medicaid. It's just like they don't have access to the state benefits databases or systems. And it's usually not really in their, there's no reason really for them to go digging in those anyways. So generally the federal government, the immigration agencies are not going to know what benefits any particular family is applying for. So there's time possibly for questions. That is the main number of our organization, and my email. If people think of questions later, you are welcome to shoot me an email. We are not really giving appointments for, like, if non-citizens want a consult with an attorney, we're kind of at capacity with appointments, but if people have, just like a short question about a particular benefit, you can shoot me an email. There's also, you can ask today.
Yeah, anyone that has questions for Sylvia, feel free to either raise your hand or come off mute or post a question in the chat really quick. We will be sharing Sylvia's handout as well as slides in the blog that's going to be released early next week. And also, if anyone has any kind of immediate questions and just wants to share something quickly with a colleague, we have written about this topic in the past in our September recap blog, and that link is in the chat right now. And if no one has any questions, I am going to be sharing Sylvia's contact information in the blog. I really appreciate your time, Sylvia. Thank you so much for being here. And I would like to, I have a question in the chat. Okay, I will share Sylvia's email. Let's see, Alyssa asks, if I have an LPR client that needs public assistance, but is afraid to apply because she hasn't naturalized yet, are there any resources I can point her to?
And I guess, yeah, so if she wants to nats, like I said, I've naturalized many people whose income were zero, who had been unemployed for decades. I've natsed people who have been on SSI for also decades. So yeah, for naturalization, you can receive, basically for naturalization, you can be completely dependent on the government for your subsistence and you can still apply for citizenship. I guess for, I'm not entirely sure which resources to point her to, but she's also just welcome, she can look at the naturalization application. The naturalization application asks 0 questions about your income, 0 questions about benefits. So yeah, it's hard. There's not really resources because it just doesn't apply. So yeah, but the government doesn't really have a, announcement saying that it doesn't apply, but yeah, income and benefits has absolutely zero bearing on applying for citizenship.
All righty, it looks like we answered that question. Sylvia, thanks so much for being here again. You're welcome to stay with us for the rest of our meeting if you'd like updates on other things. For now, I am going to pass it over to Jody to introduce us to the next section of our agenda.
Thank you, Tim, and thank you, Sylvia. This was really helpful information. I was particularly excited to have you here. When I was at Public Health, I know a lot of folks were afraid to go just even get a free vaccine or a COVID test because of those old Trump era rules. And I imagine that extends, you know, to a lot of other places for folks, and the fear that, you know, came along with that presidency. So I appreciate you being here. Thank you. I am deeply grateful for our next three presenters. We've got Susan Schold, and I hope I'm pronouncing it, oh good, yay, who's the Crisis Triage Administrator with the Behavioral Health and Recovery Division at King County. We have Diane Mays, who's the Clinical Director of the 988 Crisis Services at Crisis Connections and the Crisis Line. And then we have Freyton Castillo, who is the Associate Director of Mobile Response with DESC. This panel came about because we know kind of twofold. We know our sector has had a lot of turnover, has a lot of vacancies. We've got a lot of new folks coming into this work that just don't know this system, and it's a complicated system. So trying to help ground folks in and provide a little bit of a foundation around, you know, an overview of the system as a whole. You know, specifically, we've got the Crisis Line and Crisis Connections, but then there's this new National 988, and, you know, what are we doing locally here around those two things? And then, you know, DESC is a huge community partner that has a lot of services, serving a lot of folks with behavioral health needs. So just wanted to have folks have an understanding of what services are out there, you know, who's eligible, how people get referred, what does it sort of feel like to, like, you know, as a provider or as one of the folks you're working with, call these services. Like I said, just kind of ground folks in. I also think it's really important to acknowledge that the crisis system itself in our community is in crisis, right? And we all know that. We know that many of you are facing very, very long wait times, like hours or days, for police or medic to respond when you have a situation that is unsafe for an individual, for someone that is in crisis, where that more immediate response is needed, and that is not happening in our system. These folks don't have necessarily control over that, but I think they're very aware of that and can maybe even offer insight as to, or at least acknowledgement of, you know, that that's a reality that we're all facing, and that weighs on all of us across this system together. With that being said, the coalition is continuing to monitor developments. You know, Executive Constantine announced a package for behavioral health crisis resources that has yet to be approved by council. They just finished their budget process, but, you know, if King County Council approves that, it will be on the ballot in April. So that is something that we are tracking, and we want to make sure that we're pulling in all of our partners around whatever we might need to do around that proposal and that body of work that's coming down the pike. So I encourage comments, questions for folks. This is also a space, as always, where, you know, feel free to express some of that frustration or that anger, and a little bit of a acknowledgement that as we talk about this and services and referrals and all of the ins and outs, that might bring up situations that you or your colleague have faced. And just want to acknowledge that before we hop into this conversation. But everything is always welcome in this space, so that we can acknowledge it, have an awareness around it, to then see how we might be able to problem solve as a collective and as a community to do that. So I am really, really thankful for our three presenters. Susan, I'm going to pass the floor to you as our first presenter. Thank you.
Awesome. And I'm going to share my screen. So please let me know when it works and you can see it.
We can see it.
Fantastic. It is my pleasure to be here today. I am Susan Scholl, the Crisis Triage Administrator. I do see a couple people on the call that I do know, so that's really fantastic. In fact, I actually see somebody on the call that I went to high school with. So small world. Hi, Nancy. I am here to sort of give the brief overview of the system as a whole, which will be brief and fast. So feel free at the end to ask me questions and stuff, but I really just want to lay out the landscape here. And then we'll be passing it on to the folks at Crisis Connections and the Solution Center to really talk about the services and supports. If I can get my system to work, that would be great. Okay, so first thing to know is, so the Behavioral Health Administrative Service Organization is where we work, right? That's the King County publicly funded behavioral health system. And the structure of the BHASO, as we're called, is part of the Washington Health Care Authority fully integrated managed care model. And most services under Medicaid are funded by managed care organizations. However, some services like crisis services are available to all individuals regardless of insurance status, income level, residency, or anything else, right? We get contracted from the healthcare authority at the state to provide critical crisis services and other non-Medicaid funded services. So things that we do besides crisis include like federal block grant programs, Western state liaison functions, drug court, PACT, jail transition care, all that kind of stuff. And then we do the crisis services for all community members. Just really quick, so you sort of see how the funding works. Like we braid a lot of really cool stuff. We have healthcare authority non-Medicaid funds. We have Medicaid funds from the managed care organizations, and we have some locally funded services as well. And we use them all to try and build up a crisis continuum or a continuum of behavioral health services that are going to work for our folks in need. And this is sort of just another vision of that, of how the money flows, right? So it's important to sort of know that we try and do whatever we can to ensure that the system is funded at the level that it needs to be as much as we can. Few things to know. In our contractual obligation with the state, there are minimum service requirements that all BHASO, Administrative Service Organizations, must provide. And those are the ones that are listed here on the screen. So it's the regional crisis line, mobile crisis outreach, the designated crisis responders who do the involuntary commitment evaluations, secure withdrawal, and involuntary treatment. In addition to those, however, King County has opted to expand the minimum crisis services and supplement them with additional services. So the key basically means that anything in dark green are the things that we're required to do. Everything in light green is stuff that King County currently has and is providing additional support for through either like local funds or health or housing funds or things that are more flexible in many ways and are more under our control. This is just, there's a 2-page timeline because it gets pretty robust. But as you can see, for like the first 40 years, right, of services, we had slow growth of our crisis system services. We started out with the crisis line back in 1964 and then grew a whole bunch of like local programs while we sort of took on the role of being the crisis entity for everybody in King County. As you can see, we have like the Children's Crisis Services, which began in 2005. We had some crisis intervention training for law enforcement, which started in 2010. And then things started to get really interesting. We got really busy as of 2011. So like the last 11 years, we've added a significant number of programs to our crisis system. So we have our mobile crisis response. We have our crisis solution center, which Brayton is maybe going to speak a little bit to. We have additional crisis response for youth and young adults. We have some crisis, I call them crisis adjunct things like assisted outpatient treatment, a recovery pilot program, We have some post-crisis response services, some site-based crisis response services, and we have a couple things that are pending, right? So we have a brand new program for substance use disorder and next day appointments, which is supposed to be underway, I believe, next month. We're anticipated for the start dates for those things to be available come December 5th. We also have 2 new crisis stabilization facilities, which are going to be 16-bed crisis stabilization facilities being developed currently within the county. One's in Federal Way and one's going to be in North County. They're not under construction yet, so it's going to be a bit before they start. And then, as Jody mentioned, we have that crisis care campus levy that's proposed for next year that's going to expand crisis campus services even more, ideally, right, if it passes. I apologize for the busyness of this slide, but I really wanted to sort of show you like how the crisis service is supposed to, or how it currently operates as far as like who gets called and how do you get to a service, and then how do they, what services do they utilize? And it's really supposed to be a fairly straightforward process, but as you can see, nothing's really ever straightforward, because we get people involved in here working with crisis, from first responders to jails to community members to behavioral health providers to folks like you that work in the housing systems and such. So it is a method to the madness, but I always feel like it is when you're trying to engage with it. And then I did pull together a slide that's sort of crisis services plus. It's like crisis services plus outreach services within King County. And this is more of an attempt to sort of show you like there's a lot of reasons why you might struggle to figure out what's available in our system and how it works. Because all of the programs on the slide that you see right now are either a crisis outreach, mobile outreach team, or some kind of outreach engagement program that works with folks with behavioral health disorders. The left side of the slide is adult focused, the right side of the slide is youth focused, and it talks about who can refer and how. So we have a lot going on in the crisis system. There's a lot of, Joni mentioned, there's a lot of sort of movement with crisis right now. And I would say what the other thing that we can say is we have a lot of resources that we've never had before. The problem is we also have workforce challenges like we've never had before. And so building new programs and growing our programs and doing the things that are really going to meet the community members' needs takes some time and resources and people. And right now we have 1 or 2 of those, but not all 3. And then let me see. And then that's me. So I'm going to make sure that, of course, to put my information in the slide as well. But if you have questions or in general about the behavioral health crisis system, or just questions about behavioral health and you're looking for help and information, I can help be a conduit or a resource. Please feel free to reach out. And I'm going to stop sharing so I can pass it on to Frighten.
Oh, thank you, Susan. And actually, we're going to move to Diane next, and then Freyton. Really appreciate that. And I failed to mention to all of you, we will go ahead and we will have time at the end of all 3 presentations. But, you know, throw them into the chat. We'll be monitoring. We'll get to them. Just want to make sure we can get through all 3 presentations. So, Diane, please take the floor.
Sorry, thank you so much. I was wondering, I wasn't planning to share some slides, but I do have some. I'm happy to share them if that's okay. I think that might help the conversation a little bit. This presentation typically does take some time, so I'll try to be brief as best I can, but give me a second here and I'll go ahead and share my screen so you can all see that.
That sounds great. And just for everybody on the call, I did the terrible facilitator thing to all 3 of these folks. I said, give me all this information and you have 13 minutes to do it in. So I'm just going to acknowledge what I did to all these folks, and they are graciously walking with me down that tough road. So Diane, take it away.
That's okay. I could verbally give the highlights and then I realized, oh wait, I do have a presentation. So sure, let me, as introduced, I'm Diane Mays. I'm the clinical director for 988 Crisis Services at Crisis Connections. So we are one of 3 call centers in Washington State that do respond to 988 calls. And I will talk a little bit more about the 2 other programs as well, but our program specifically serves King County. So that is one of the nuances between the 3 different programs, is that we each do serve different counties. So as you know, some of you may have heard, I know it's a new number. It did come in. The intention on the national and the state level was to essentially have our launch in July 16th as a soft launch. So there has not been a lot of marketing, a lot of campaigning around it. There has been some media. There certainly have been some interviews and things that Michelle McDaniel, our CEO, has responded to, and there's certainly been a lot of coverage in the press. But if you haven't heard a lot about it, it's because that was by design, that it would be rolling out in July with a soft launch and with more to come as we grow and as it becomes more established. So in essence, 988, it really is designed as that a 3-digit number similar to 911 for people who are in emotional and behavioral health distress, and because it is built off the National Suicide Prevention Lifeline, ideally also those who are having suicide ideation as well would think of us as a quick resource for help and support. And it has, and I'll talk a little bit more about the history, but it has been in existence since 2005, the National Suicide Prevention Lifeline. But this new iteration of 988 being the way to access went live in July of this year. So that's when the transition happened, when the name change occurred. Again, I think speaking to a population who understands the need for crisis services and why we're here and why 988 really did come about. But really, you know, without reading all the statistics and information, it's really using this number as a first step to kind of create a fundamental shift in how people engage and are supported in our mental health and behavioral health system. So it's really a step towards transforming the system in much the same way that 988 or 911 did when it came to emergency medical responses. You know, we're ideally going to get that connection to those who need help, get it more quickly, and get them directed to the right resources. And also reduce the stigma associated with reaching out for behavioral and mental health response. This is just an overview of what the National Suicide Prevention Lifeline started as, where it's been. So it originally launched in 2005, as I said, by SAMHSA and Vibrant Emotional Health. When I started at Crisis Connections in January of last year, or this year, sorry, it feels like it's been forever. This year, there were about 175 call centers nationwide. Now they have grown to over 200 with the impetus behind 988. So not only is it expanding our access to service, but it's really causing this momentum across the country to activate more areas to be more involved. So all centers do operate 24/7. You know, and Lifeline's goal was really to stand behind, create the messaging, establish best practices in mental health, especially crisis phone work, and create partnerships that help it grow and expand as it has. So this slide here, particularly on the right side of the diagram, lays out what a caller can expect when they call 988. So they call, at that time it was still the 800 number, but they called the 988 number. They will get 4 voice prompts. They get 1 to be routed to a veterans crisis line. They will get 2 to be transferred to a Spanish subnetwork. They could potentially press 3, which is a new teen and youth LGBTQ line that is being piloted that went live in September of this year. So already there have been some quick changes that have been happening. And then in November, actually just last week, there's also the prompt number 4 to reach the Native and Strong Lifeline, which is led by Volunteers of America, one of our other call centers here in Washington State. And that is for Washington State callers specifically. So just even since July, we've already seen expansion happening in the resources available. But if they don't press the prompt, they're going to get routed to whichever call center is affiliated with their current area code. So they are routed by area code currently. So someone who calls in, like I have a 425 area code, obviously I'm going to get routed into my own center. My children have 425 area codes, but they live in Austin, Texas. They're young adults living there. And so if they called, they also would get routed back to King County. However, we do have the ability, because we are a national network, to look up call centers in the area where someone is located. So we can reroute them or redirect them to a local call center too. So that is one of the pieces being part of that national expansion that we have. So just wanted to highlight with that slide. And I'm certainly sure there'll be a ton of questions about that specifically. This is just an example of where the Lifeline was in January of this year. And like I said, I haven't seen the recent map, but I can tell you that it has expanded considerably just in this year alone. As far as 988 becoming a number, it's had quite the journey. As I said, starting with this National Suicide Prevention Lifeline, there was conversation as far back as 2001 with SAMHSA wanting to develop this broader network of call centers. And then it has continued and more phases have come on leading up to 2019 when the conversation started and really started to grow around designating 988 as a phone number. So this is something that's been a work in progress for quite some time. In 2020, the national 988 was designated as a law on the national level. And then last year, actually, Washington State, we passed House Bill 1477, which helps funds this. So there's some national funding and there is state funding that comes from growing the lifelines. And in Washington State, we happen to be one of the leaders in funding, and it's been really helpful to help us get up running quickly and effectively and to start to grow our services and outreach in the community. And this is a little more insight and information about House Bill 1477 that was passed in Washington State. And it really, again, the goal is to increase and grow our behavioral health crisis system statewide. And also with that, not only we're starting with the phone line, but also we're looking, it's also designed to help fund resources such as youth and adult outreach, including the mobile crisis response teams. Also talking about creating more expanded next day behavioral health appointments, as well as working and collaborating together with other partners such as 911 on how we can best continue our conversations and collaborate together to increase our network and approach and response to behavioral health. And there will also be some technology pieces that come with that. As far as Washington State, as I mentioned, we are, if you look at this map, we are highlighted in blue as crisis connections. So our services currently serve all of King County. And then in the areas highlighted in orange, that is served by Volunteers of America from the 988 perspective. I will say at Crisis Connections, we also serve on the regional crisis line, we serve King County as well as 8 other outlying counties. And so, we do rely on our regional crisis lines too to help with transfers and sharing of information when it comes to passing callers to the appropriate network. So if someone has a King County area code, but they are currently in Snohomish County, those are some calls that we frequently get. We can also make sure they get connected to regional crisis services as well. So being in the state, we do have some great ways to connect with one another to ensure our callers are being served. Also in the Spokane region, there's Frontier Behavioral Health. And so they serve as the 988 provider for the greater Spokane region. Also with us at this time, Volunteers of America is piloting the text and chat feature. So if someone texts and chats 988, those calls will be routed to VOA at this time. However, we are in conversation with Vibrant to also begin to add that feature specific to King County, where we would be serving King County text and chatters within the next year. So this is something that we are actively working on to grow our service and response to the community that we're in as well. So the other thing, a question that comes up is regional crisis lines. So regional crisis lines are still operating. Those numbers are still available. We still do, and people are still in the habit of calling those. Encourage them to call them. These slides have changed a little bit since I originally put this presentation, and on last notice I didn't get a chance to change all of these slides, but currently the regional crisis lines, especially ours at Crisis Connections, this is our internal team, does the mobile crisis team referrals for adult and youth. They also are the response center or call center for making connections to the designated crisis responders. We also have placement care coordination, hospital authorization, a number of other services, including the next day appointments. And So as I said, our goal at 988 specifically when we first rolled out was to answer that call. Since then, we have created some MOUs with King County so that we also now can make that connection with the DCRs, MCT, and youth and next day appointments as well. So this was, as I said, the slide was from the beginning, and we've already evolved into being able to navigate those pieces ourselves. So something, again, when the slide was created was what else are we doing? Well, a unique feature to 988 specifically is that we also provide follow-up calls. So when someone calls in, they aren't at significantly high acuity that they need, higher level of intervention at the time, they can create a safety plan with us. They can say that they, will be safe. They would just like someone to check in with them, support them as they connect with resources that we've maybe provided them, or just, see what next steps need to be with them. So part of House Bill 1477 funding and guidelines does recommend the use of peer support and follow-up calls. And so we do have a certified peer counselor working on our team who does make those outreach calls. We've been making those since September. And currently, I think, she's getting probably maybe 10, 15 or more a week. I mean, she's getting quite a few, which is great compared to not ever having had that service before. So this is something that we're continuing to see grow since we started. But they make those follow-up calls, they check in with the person, see how things are going. As a peer counselor, again, they use that peer support to help them advocate for themselves to get the care that they need, but also remind them that we're here for support when needed too. So we do also have the ability to identify if they call us back in terms of she's done some outreach, maybe did not connect with them, and then that person then calls us back. We have the ability to make sure that we try to connect with them. She does make 3 attempts to connect. In some cases, they don't, aren't available, they don't take the call, they don't follow up with us, but a large percentage of the time she is making those connections and getting really positive feedback that, they're appreciative of the service, they're glad someone's checked in with them, and that, they're either okay, validate that they're okay, or how we can help support them further if they need it. So this has been a really, really great tool, and we're starting to gather the feedback on that and really seeing a positive response so far. Again, as I mentioned, we are already now at that point where we are providing the mobile crisis referrals, the designated crisis responder linkage. However, one of the pieces that is coming with the national level of 988 implementation to come probably farther down the road, a couple of years, I anticipate, will be the ability to add geolocation. So rather than routing by area codes, we're able to actually route by where the person physically is. So we have maybe less of that concern about, dropping someone or not getting them connected to local resources, or some of the, things that can happen in that. We can make a smoother transition and or meet their needs better in that position. So there's more to come. There's also continuing conversation on expanding the next day appointments on the state level. So this is part of the conversation we're starting to have now, and something that we can look forward to going forward. Another piece that we are doing, and I know this is a common concern and one of those maybe pieces of misinformation that was out in the community, is that when people call 988, that we are automatically going to call 911 and police response or emergency response was going to be activated. That is not the case. We have been working very closely with 911 to make sure that we understand how our systems work, how we can best communicate. We're working on some process mapping on how we can make sure that they can either refer behavioral health response calls to us without the need for police intervention, as well as us, recognizing that we do already have a system to activate 911 if needed. But we're also looking at, hey, how can we smooth this process? So this is an ongoing conversation with us and with 911. So, but as far as the community is concerned, we each have our own processes in which we evaluate the person, evaluate the situation, and determinations are made based on obviously risk and, awareness of what's happening with the situation. And in every case, we do our best to inform 911 responders if or if DCRs are going out, if police response is needed, if we know there are weapons in the home or some risk of someone being injured, higher risk than suicide risk, or others are involved, I guess I will say. We are having those open conversations, and this does continue and will continue as we grow. And then, as I said, we continue to work on mapping out and coordinating with our regional crisis lines. At Crisis Connections, we are fortunate in that our regional crisis line and our 988 team are housed in the same organization. So we have a great flow of communication, but we are a large state and there are several regional crisis lines affiliated with different states. And so we're working to smooth out that process for everyone across the state so that we can have this more integrated system of care as the program is designed to have. And hopefully I talked fast enough. That's essentially my message. But my reminder to everyone is that we are all the lifeline, right? So I stand as a representative of the 988 Suicide and Crisis Lifeline. However, we all have that opportunity to utilize the services and reach out to on behalf of someone we are care about or are concerned about, or provide that referral that they may contact this number. So we're really looking to expand the crisis, current operations as they are, and to continue to grow and support those who are in need in behavioral and mental health crises. And that's it. That's my contact information. I'll be happy to share that in the chat as well if anyone has follow-up questions. And that is my part.
Thank you, Diane. We do have one question in the chat. I'm going to hold it until Freyton is done. So keep throwing them in there. But Freyton, I want to hand it to you. Please take the floor.
Awesome. Thank you. I will share my screen. That works. Perfect. All right. So hi, everybody. Thanks for having me. My name is Freyton Castillo. I am the Associate Director of Mobile Response through DEST. So I oversee programs that are rooted in crisis response, post-crisis response, and outreach. The programs within my portfolio I will focus on today include the Crisis Solution Center, the Mobile Crisis Team, the Behavioral Health Response Team, and Mobile Response Team. I will decipher what all that means in a little bit. So within this division, we serve on a continuum of services that range from imminent crisis to post-crisis and outreach. The first program I'll talk about today that's not included in these slides is the Crisis Solution Center. The Crisis Solution Center, for those that aren't familiar with it, is a voluntary 24/7 facility that is rooted in addressing imminent crisis response for, excuse me, for folks experiencing any type of behavioral health crisis. So that it consists of two projects: the Crisis Diversion Facility, or CDF for short, or Crisis Diversion Interim Services, or CDIS for short. So when folks get referrals, well, before I get to the referrals, with the Crisis Solution Center itself, it's 24/7, it's voluntary, and it's a completely free service for clients. So they don't have to worry about the financial implications or insurance or healthcare benefits piece to that. We were funded through the MID for that program. And so, it's split into two programs. The first program, the Crisis Diversion Facility, they take referrals from law enforcement, fire, DCRs, our mobile crisis team, which I'll go over in a little bit, and hospital EDs. And so, when someone is experiencing a behavioral health crisis, which is a broad range of different criteria, they get referred from one of those referral sources, and then they get transported to the Crisis Solution Center and the Crisis Diversion Facility, CDF, specifically, where our focus is crisis stabilization and helping someone get their basic needs met. So providing people a safe space to eat, sleep, hydrate, take a shower, do some laundry, and physically get away from a crisis space or the crisis environment, where they would have 24/7 support from a multidisciplinary staff, which includes MHPs, case managers, peer specialists, SUD staff, medical staff, which includes nurses and prescribers, where they can stay in that safe environment for up to 3 days, again, where they can achieve that stabilization. Through that time, they're getting that 24/7 support from staff, and also, working on some working on identifying some goals to, identify how can we address and hopefully resolve this crisis within that time period. As you can imagine, 3 days is not a lot of time, so we're really focused on that basic need component and helping someone recharge their battery and reset from that crisis event or situation or environment. Beyond those 3 days, folks are either discharging back into the community, and throughout that whole time, folks are in the facility. We're discussing discharge plans and safe discharge plans with folks, and going over plan A, plan B, plan C, just to have a slew of different options. If someone isn't discharging, and we see that someone will benefit from being at the facility longer, we would refer them to the Crisis Diversion Interim Services, or CDIS for short, which is the second part or portion of the CSE. Their only referral source is CDF, and so no one's bypassing that stabilization portion of their crisis stabilization part before moving on to this portion of the program. CDIS's main focus is establishing connections out in the community. So essentially picking up where CDF left off and trying to solidify connections or reconnect folks back into different resources and supports that could be helpful in helping resolve and hopefully prevent future crises on the road. And so within this facility, there are 30 beds. I forgot to mention CDF has 16 beds. And so within CDIS's 30 beds, again, we are focused on establishing connections out in the community. So that could be, if someone on CDF, for example, has identified, getting tiered or getting connected to a case manager as a goal, but that's basically where we could get. If someone was to transfer to CDIS, we could really look at the ins and outs of where would be the best place based on where they stay and where they're comfortable. Have they had previous connections before? Do we reconnect that person? How can we coordinate care with these either existing or new providers? And how can we continue to work on a more developed discharge plan eventually? Folks can stay up to 14 days at CDIS. And so again, during that time, we're really focused on establishing and strengthening those connections out in the community. Within this whole CSC program, folks are able to, leave to go on appointments and return. And so, really trying to make use of that time within that facility to, again, create and strengthen connections out in the community before folks transition back out into the community. And then moving on to the next portions of the program. So this slide here is related to our outreach teams, and I'll go into some detail about what they are quickly. So the first one I'll talk about is a mobile crisis team, or MCT for short. As we've grown and expanded within our scope of the services that we provide, the mobile crisis team has actually expanded out into its own program. Previously, it was under the CSC umbrella, but we've been able to expand the team to strengthen its and increase its presence out in the community. And so it's defined as its own program now. With the mobile crisis team, this is also a 24/7 program, and it's designed to outreach folks experiencing any imminent crisis within King County or anywhere in King County. So we have a pair of clinicians going out into the community and going into the environment where folks are experiencing their crisis situation. They get referrals from law enforcement, fire, DCRs, and crisis connections, which 988 calls are now looped into the crisis connection piece now that that's live. Again, mobile crisis team scope is being able to provide imminent crisis outreach to folks experiencing any type of behavioral health crisis, to folks over the age of 18. And we are operating, with our expansion, we are operating out of 3 different offices in order to provide that service and to shorten ETA time. So we have an office at the Crisis Solution Center, which is our central location, which is located in the International District, so mainly that Seattle area. We have a south office in Kent to address all of our South King County calls. And then we're currently developing an office up for North Seattle in Northgate, that's currently in development. So we're working on trying to move in very soon, now that we've been able to expand the program. So in terms of focus, mobile crisis team, again, working with folks that are experiencing any type of behavioral health crisis anywhere in King County, and any adult over the age of 18. Again, it's a 24/7 program. In terms of referrals, again, law enforcement, fire, crisis connections /988 and DCRs. When we get those calls, all of our calls now go to a centralized dispatch team that will disperse calls out to these 3 teams, which I'm about to talk about on these slides, just to make it easier for the referents, just so they don't have to navigate, which team is most appropriate for this call. Referents can just call and say, hey, here's who I'm seeing in the community, and we will dispatch them through to the appropriate team. For MCT purposes, the least minimum information needed is location and crisis description. From there, our team can go out and outreach the individual in crisis. In terms of services, as MCT clinicians are going out into the field, they're looking to resolve that crisis typically within a 30 to 60 minute time frame of meeting the client. We do have a goal of trying to get out to the scene within 60 minutes. Now that we're looking to expand our services, but we're looking to really try and address and resolve that crisis in that space, whether that's talking to the person, helping get some basic needs met, referring them to a new or existing resource, and possibly transporting them to see their case manager or their medical provider. Again, just trying to really be really creative out in the field to try and figure out how can we help resolve this crisis, in this moment. And so, again, this service also looks to divert folks from either hospital or any jail stints. Just like with the Crisis Solution Center, we try to divert folks from those types of environments if possible. We also do work closely with the DCRs to assess risk for the individual that we're seeing in the event that they're needing a higher level of care, or whether we're consulting with DCRs in particular around folks that we both might be familiar with. Same goes with law enforcement and the other referring parties. One sub team under the MCT umbrella is the Crisis Response Team, or CRT. They're doing similar work to Mobile Crisis Team in that they're doing imminent crisis response, but instead of having 2 clinicians, which could comprise of an MHP, a case manager, or a peer specialist, with CRT in particular, they're doing a co-response with an MHP and an officer that's crisis trained with SPD. And this team is housed in the SPD East Precinct. And so they go out on calls directly with law enforcement. The next program I'll talk about is the Behavioral Health Response Team, which is a newer program. We were just in a pilot phase of this on a smaller scope in 2021. We just got off of that pilot phase of July of this year. And now this service is now going King County wide. So the Behavioral Health Response Team is different from the Mobile Crisis Team in that they're doing post-crisis response. So someone that's not necessarily in imminent crisis currently, but might be coming out of a crisis situation, or might be a familiar face or a high utilizer in different entities, like with law enforcement that they're seeing, or other referrals. We do get referrals from fire, law enforcement, and a mobile crisis team, and we're currently working with something called the Third Ave Project with PDA and an organization called We Deliver Care, WDC, to address presence on Third Ave. That's still in development, but that should be, we're currently working on that piece for the Behavioral Health Response Team. Again, with BHRT, what they're doing is they're providing that post-crisis support for folks to really look at it from a not just a post-crisis standpoint, but also a preventative standpoint to hopefully prevent folks from getting to that crisis point before getting access to services. Really just trying to get at folks that are possibly falling through the cracks, that aren't going to the hospitals or to get that help, or are encountering law enforcement on the community, but again, not hitting that crisis threshold. This team is also good.
Sorry to interrupt you, Freyton, but I think I just wanted to tell you we probably need to wrap it up in the next 4 minutes,
okay,
if that's okay. Thank you.
Yep. Yeah. So, and again, I will give Jody these slides so we can disperse it for the more kind of in-depth thing. But with BHRT in particular, again, that post-crisis response, they're getting referrals from those referral parties. This team is also multidisciplinary. They're going out and as opposed to MCT, which is a really quick touch point, BHRT is able to work with folks for up to 90 days to really serve as that warm handoff and really try to get folks connected out into the community, and both within traditional and non-traditional services, whether that's a case manager, doctor, faith-based group, community center, that sort of thing. So again, just really trying to wrap folks into their communities and disrupt cycles of crisis, and really just trying to again serve as that long-term handoff. The last program I'll talk about is the mobile response team, which kind of takes elements of mobile crisis team and behavioral health response team and wraps it into one program. This team in particular provides both crisis outreach and some time-limited case management to folks in permanent supportive housing and health through housing emergency shelter sites. This team is contracted to provide that service to 12 of those permanent supportive housing sites and 10 health through housing sites throughout King County. And so if someone, so we do have a crisis component and a case management component that can work with folks for, either 30 days if they're connected and we can just help to reconnect them with any service providers, or up to 90 days if they don't have any current connections, and again, we can help facilitate that process. Again, this team, MRT, is specifically limited for folks that are in those PSH or health through housing sites. And we're meant to be an additional resource to someone's existing care team or their housing care team to help folks navigate through crisis situations, get connected to helpful resources in the community, and hopefully help someone maintain success in that housing placement so that folks can continue to engage in their recovery. Again, I will send these slides over to Jody, so you all can take a closer look, and feel free to email me and let me know, contact me if there's any questions specifically to any of these programs. BHRT and MRT in particular are very new, and so I'm sure there's gonna be a lot of questions, but please feel free to direct them my way. If there anything pops up.
Thank you. Really appreciate Susan, Diane, and Freyton for your just a wealth of information. And I just have to own and apologize that I did not accommodate for enough time to really cover this in the way that I think we all need. So I think what we'll do is we'll collect your questions, and I will follow up with our wonderful presenters and see if we can't, we'll get the slides for you, we'll get questions answered, but see if we can't maybe even expand some resources that you can share with your teams. I saw that in the chat, but we are also looking at how we can build on these trainings and maybe a fuller training as we move into 2023. So really appreciate all y'all's time. There is clearly, this is a huge complex system that is moving quickly coming down the pike. So on that note, I'm going to hand it over to Allison.
Thanks so much. I see just one quick question from Todd. Is 988 the best non-911 way to get in contact with the mobile response team?
I'll go ahead and answer that if that's okay. I mean, certainly they can. As a lot of people are still familiar with and still are comfortable with using the regional crisis line. So again, they continue to work as they always have and will. And they have some positions that are more direct linkage positions than we do built into 988. But as I said, we still partner with the same systems. And so either one will get you there. I guess that's the best way to say it. So 988 is fast to get the call through. Don't have all the 10 digits to worry about, but at this time, either number is appropriate to call.
Great. Thank you so much. And I want to add my thanks to the folks who presented. I suspect that some of what is going on is that despite the fact that there are new additions to the response system, particularly for folks who are already in some way connected to services, it is still not adequate to meet people's needs. And so there's a lot of frustration, which I just see from reading the chat, in terms of the need for a quick response for people who are having a crisis and not always finding the response to be as quick as needed. But really happy to have begun to have this conversation. So thank you to all the presenters. Thank you, Jody and Tim, for pulling this together. And we'll just continue to build on this. I'll introduce myself, Allison Eisinger. I use she, her pronouns. I'm the director of the Coalition on Homelessness. And we are going to switch gears now because, as many of you know, we are in budget season. This is a crucial time in our work as a coalition to do the advocacy to get the resources in city and county budgets that are necessary to respond to the crises of homelessness, lack of affordable housing, inadequate behavioral health systems, and many other things that make this work so important and so difficult. So I will invite you all to just stick around because we have some good news and things are not completely complete. As many folks who may know who've been paying attention and coming to coalition meetings, reading emails, you know that this budget season we had to fight. We, the coalition, all human services providers had to fight for something that we shouldn't have had to fight for, which is the legally required adjustment to human services contracts at the City of Seattle to help them not even keep up with inflation, but not slide further backwards because of record inflation. Lots of you were involved in the work that we did together with other organizations, including the Seattle Human Services Coalition, OPEIU Local 8, and SEIU 1199 Northwest in 2019 to pass an ordinance in Seattle requiring that the Human Services Department contracts do keep up with inflation. And yet we learned from the mayor's introduction of a budget that Mayor Harrell sought to do what he referred to as a 4% inflation adjustment, but what was really actually only a 1.2% adjustment over the 2022 contracts. So we all went to work and you all went to work. And I want to tell you, pro tip, as we like to remind each other and ourselves here at the Coalition, advocacy works. If you've ever taken a workshop with Nancy Amadei, you know that that's one of her favorite tag phrases. And indeed, advocacy works. We work together, and agencies and programs and our community partners and folks from organized labor stood up and joined together and used lots of different approaches to, we think, secure the 7.6%, not quite the full 7.6 that we were hoping for, but the 7.6% inflation adjustment that is in the balancing package now at the City of Seattle, which will be voted on next Monday, and then the budget will be adopted on November 28th, unusually after the Thanksgiving break. So how did we do that? Well, among the things we did, almost 200 people sent almost 700 emails to city and county council members in the space of about 2 weeks using our quick email system. We had a fabulous rally for human services, and I'm going to ask one of my colleagues to put in the chat. I edited our document for the membership meeting, and there are some links that we want to share with you all. There's a link to our YouTube channel, so if you missed the Rally for Human Services and Dignity last Tuesday, November 8th on Election Day, no worries. You can hear the powerful firsthand accounts from frontline service staff, as well as really, I will say, inspiring words from City Council member Lisa Herbold and Martin Luther King County Labor Council Director Katie Garrow, as well as a rousing closeout by Seattle City Council member and Budget Chair Teresa Mosqueda, explaining not only are we not going back, but adjusting for inflation is the bare minimum. What we know everyone needs is wage increases. And we need to make sure that agencies and that our workforce stabilize and that we don't slide further back, and we need wage increases. So the other piece of really fantastic news is that we worked very hard with the King County Executive and the King County Council, and we won $5 million for homeless housing and service providers in the King County budget. So before we run out of time, I understand that you all, before I joined this morning, previewed the idea of doing a group photo of thank you signs. So I made my little thank you sign. I'm in New York visiting my parents, and I'm just going to ask if everyone would please come on camera, hold up your thank you signs, and let our wonderful Rachel Marr take a photo that we might be able to use as we express our appreciation. I love the pink Post-it note, Monica. Hold it up. Be proud. Doesn't matter. I love it. And if you don't have one made, right on, Kylie, then go right ahead and you can just scrawl on whatever piece of paper or folder is closest to you. Awesome. And I'm not exactly sure, Rachel, how you're doing this, but you give us the high sign when we're done. Thank you. Are we okay? Yeah, great. All right. Thank you so much, everybody. If you want to, feel free to take a selfie of yourself with your thank you sign, because that might actually be slightly better quality. Just very quickly, among the things that we also did is we worked closely with Catholic Community Services and the Seattle Office of Housing to make sure that the Home for Good program didn't fall through the cracks and that 54 people did not lose their housing subsidies and case management. We worked really hard to try to lift up the critical importance of maintaining the healthcare for the homeless network's capacity. We don't think that additional funds were put into the budget, but we have alerted the council members and the executive and Dr. Khan, who's the new head of the public health department. We've requested a meeting with Dr. Khan, and you will be hearing from us because we're not letting go of that important element of our collective work. And we also hope that you will join us in December. You may have noticed when you registered for this meeting, we asked about the homeless service provider stipends. Not everyone who comes to our meetings is a homeless service provider, but if you are, we want to make sure that you get your stipend. These are the state stipends. And if you have any questions about that, there's information on our website, or send us an email and we will make sure to connect you. And of course, we understand that stipends are really important. Folks have shared with us some stories about the differences in their own lives, particularly with everybody's rent going up. And we will make sure that the state lawmakers who helped us secure that stipend program hear from you all what the effects of those stipends have been in your lives. Because we think that there's a possibility that we will be advocating on that topic as we go into the state legislature. There's more to come on that. Just to be clear, again, we are advocating for the wages in this sector, not just for stipends, but we also know that it's really important to work on multiple levels at once. So Tim just put the registration in the chat. Thank you so much, Tim. We'll be asking the same question again in the December meeting, and our December meeting is 2 hours, state legislative preview. Number of excellent people got elected to serve, to represent us in the state legislature. So remember, the reason we ask for your home address when you register is so that you can know who represents you at every level of government, because that's an effective way to be part of the advocacy. I think I'm going to leave it there because I think we're right at time.
There's a question. You can send that question from.
Right.
All right, thank you so much, Allison. And thanks everybody for taking a picture to celebrate all of the achievements that we made this session, this budget season. I see that it is 10:31, but I quickly just want to encourage everyone again to join us at our next membership meeting in December. We are going to have a legislative preview. We're going to be joined by legislators, community partners. Is it December? It should be December 15th. We'll see you there. Registration link is in the chat. We also have some great opportunities shared by Recovery Cafe. I'm going to share more information about those in the blog. I'm going to get those flyers to pass on to you to make them available in the blog. We also, I think we might have a quick bit of time available for an announcement on a new program expansion kind of thing available from Catholic Community Services. Do we have Teresa or Trisha here to share a little bit about that? If not, we will post that in the blog. I know we are over time, but I would love to take a moment and hear from anybody who would like to come off mute or share in the chat any opportunities, any updates on what is going on in their networks, in their community, in their organizations. We'd love for you to share that.